ahead with the next presentation, and we'll have a joint discussion at the end. May I invite Dr. K.K. Kapur, who is going to speak on echo and aortic dissection, what is new. Dr. Kapur is currently a senior consultant cardiologist at the Apollo Hospitals in Delhi.
Thank you very much. I would like to thank the scientific committee for inviting me to give this talk. And my talk is on echo in aortic dissection, what is new. So I'll first give an introduction to this topic and then go on to some of the newer advances. The earliest documented case of aortic dissection is attributed to Frank Nicholas, who in his autopsy report of King George II of Britain, who was found dead in October 1760. But the term aortic dissection was introduced by the French physician J.P. Monnoyer in 1802, and the surgery for aortic dissection was developed by DeBakey in 1954, who also gave the DeBakey classification of aortic dissection. And it is interesting to note that he himself developed aortic dissection at the age of 97. At that time, there was a lot of debate whether he should go in for surgery or not, but ultimately it was decided that he should go for surgery, and he survived that surgery and died a couple of years later. In 1984, Borner et al. First reported a transesophageal approach to aortic dissection, and the first 3D echo assessment of aortic dissection was given by none other than Dr. Nanda in the Echocardiography Journal of 1998. Now, aortic dissection is a relatively rare, but it is seen all the time with an estimated rate of 2 to 3.5 per 100,000 people every year, more common in males, and the mean age of diagnosis is 63, although we have seen a lot younger patients, especially with a Marfan syndrome. And amongst the causes, although hypertension is the most important cause, Marfan syndrome is becoming more and more evident that, and the annulo-aortic ectasias of various types like the Ehlers-Danlos syndrome or pseudoxanthoma elasticum, connective tissue diseases, the bicuspid aortic valve. And when you take the classification, you have the DeBakey classification and Stanford A. In the DeBakey classification, the intimal tear occurs in the ascending aorta, and the dissection process extends all along across the aortic arch into the descending thoracic aorta, while in DeBakey 2 it is limited to the ascending aorta and does not extend into the aortic arch or the descending aorta. In DeBakey 3, it starts at the aortic isthmus and goes down the descending aorta, extending for variable extent even up to the abdominal aorta. The Stanford classification, the DeBakey 1 and DeBakey 2 comes under A, that is the proximal dissection, because that has a different prognosis, and this is the classification that is usually followed because of the prognostic implications. And the type B is the distal aortic dissection, which corresponds to DeBakey type 3. We have a newer classification, which actually the class 1 and class 2 are similar to DeBakey 1 and DeBakey 2, but class 3 also includes a localized aortic dissection, a very localized area of aortic dissection just in the proximal ascending aorta, and the class 4 is a localized dissection at the aortic isthmus, and the class 5 is actually an intramural hematoma which extends into the descending thoracic aorta after rupturing the intima. Mortality is very high, and this is what has come up, is that 40% of the patients with aortic dissection, mainly type A, they will die almost straight away and will not reach the hospital in time. Of the remainder, 1% die every hour, making a prompt diagnosis of dissection type A and the management extremely important. And if you go further, the type A aortic dissections, if left untreated, kill 1/3 of the patients in the first 24 hours, about half of the patients in the first 48 hours, and 3/4 of the patients over the next 2 weeks. The type B aortic dissection has a lower mortality rate of 35% or so, but is still significantly higher than those who are treated surgically. And now the treatment as has come up for the type B is the use of stent grafts. So the endovascular treatment of type B is a newer advance that has come up, and almost all the type B aortic dissections are now treated by the endovascular approach, and you have some time to really work up the patient, and it's not that much of an emergency as is type A. The potential lethal complications of type A dissection is because of the proximity to the heart, the intrapericardial aortic root, and the proximity to the head and neck vessels. And the effect of type A dissection, therefore, could be acute severe aortic regurgitation, which could be either due to the acute dilatation of the aortic root, the leaflet prolapse, the prolapse of the dissection flap, or associated bicuspid aortic valve. Then you have the coronary ostial occlusion, and many times the acute infarction could be actually due to the ostial occlusion, and then the use of the thrombolytic therapy could be catastrophic. So that is what should be excluded before you start a thrombolytic therapy. It can extend into the pericardium and cause pericardial effusion and tamponade, and extension to the head and neck vessels can cause stroke. So therefore, what has come is that the early diagnosis and treatment of this illness is critical for survival. You have various diagnostic modalities available. Now the pivotal position is occupied by a transesophageal echo, whether or not preceded by a transthoracic echo. If the echo window is suboptimal and the facilities for transesophageal echo do not exist, then in that case a CT or an MRI can be done. But the pivotal position, because it gives a lot of additional information which I'll be talking about. And if you see that the sensitivity of transesophageal echo for type A dissection is almost 100%, 95% for acute and subacute 100%, which approaches that of MRI, while the sensitivity for transthoracic echo is much lower, especially in type B aortic dissection. In type B aortic dissection, you always have to go in for a transesophageal echo, and there the sensitivity is equivalent to that seen in MRI, and higher than that seen in the conventional CT. And if you see the advantages of transthoracic followed by a transesophageal echo, you can classify the dissection very well. You can localize the intimal tear, the entry tear and the re-entry tear. You can quantify the aortic regurgitation, and you can also detect pericardial effusion and tamponade. What the accuracy is somewhat less for detecting mediastinal hematoma or the side branch involvement. But again, when you see the coronary artery involvement, the transesophageal echo is very good to see the ostia, the dissection flap extending into the coronary arteries, and here the 3D TEE is better than 2D TEE. And of course, it avoids X-ray exposure. Transesophageal echo may not be the most comfortable procedure for the patient, but is certainly a very safe procedure, even in patients who are hemodynamically unstable. There is a general impression that in a hemodynamically unstable patient, one should not perform a transesophageal echo for dissection. That may extend the dissection process, but that is wrong. The transesophageal echo should always be done to confirm the aortic dissection. The intraoperative availability, of course, is there. And then in a comprehensive meta-analysis of all three modalities, they all reported that spiral CT, a transesophageal echo, and MRI, they almost have 100% sensitivity or specificity. Of course, there is no such thing as 100%. It depends upon the population that is studied. But suffice to say that all three have a very high sensitivity and specificity. It's only for the particular advantages like looking for intimal tears, looking for coronary artery involvement, and looking for the LV ejection fraction, to look for aortic regurgitation, cardiac tamponade, where echocardiography scores over the other non-invasive modalities. The conventional CT has a lower sensitivity and specificity. And if you compare the TE versus MRI, both are non-invasive techniques, are safe, but the issues related to a patient transportation, because MRI is not freely available everywhere, a limited patient access, and a longer examination time than a transesophageal echo, these factors weigh heavily in favor of a transesophageal echo.
I'm sorry for the interruption, Dr. Kapur, we have virtually run out.
So why echocardiography is supportable and can be taken to the emergency department? Image acquisition is rapid, safe, and even when the patient is hemodynamically unstable, no contrast or radiation hazard, reproducible and cost effective. And as I told you, you can get other critical data relating to the LV function, aortic regurgitation, pericardial fluid, and also look at the etiology like Marfan's or a bicuspid aortic valve. However, the transesophageal echo, you do not see that blind spot between the origin of the innominate artery and the left common carotid artery. And of course, it is somewhat operator dependent. And if you see that it's a class 1 indication, transesophageal echo, transthoracic echo followed by transesophageal echo is a class 1 indication. And it's only that when you look for side branch, that it is inferior to angiography, but otherwise, and to look for the organ perfusion, that it is inferior to angiography. Otherwise, for looking at the ostium of the coronary artery, especially the 3D TE, it is much superior. So the live 3D echo provides an accurate surgical view due to its enhanced ability to identify and pinpoint the exact location of the abnormalities, and 3D TE is certainly better than 2D TE in the entry tear as well as the quantification of the size of that tear. Now this is a DeBakey type 3 or Stanford B. This was a routine examination in a patient who was going for the renal allograft, and we routinely check the abdominal aorta and the pelvic vessels to see the suitability for renal allograft. And we accidentally detected type B aortic dissection both in the cross-sectional view and the longitudinal view. 3D TEE showed the entry tear very well. So this was the 3D TE in this particular patient. We have another patient who developed dissection of aorta following a bypass. Now that is again an etiology because of the fact that you cannulate the ascending aorta, and in that process sometimes you create an intimal tear which later on could extend and could dissect into the, so this was a type 1 aortic dissection which we have located actually from the back because the transthoracic window was not good and the patient had a left pleural effusion which allowed an excellent access to the back, and we could see the flap in the descending aorta very clearly.
I'm sorry for interrupting,
Yeah,
Dr.
just
Kapur.
give me 1 or 2 slides more. And this is a flap that is prolapsing into the LV outflow tract in this patient who has severe aortic regurgitation. Another example of type 2 aortic dissection, where you can see the flap in the ascending aorta and the aortic arch on a 2D and a 3D transthoracic. And this is a 2D transesophageal showing the entry and the re-entry tears very clearly in the dissection of the thoracic aorta. Another patient with a dissection of the ascending aorta, it looks like another aortic valve just distal to the actual aortic valve, but that is actually a dissection flap. And this is showing the involvement of the LAD ostium, I mean the left main coronary artery ostium, in this patient with a 3D TEE that was well demonstrated in this particular patient. And the ostium detection, when you see, is much higher than with the computed tomography. 3D TEE has a higher sensitivity than a 2D TEE, both for the right coronary ostium and the left coronary ostium. There are some of the other examples of a 3D TEE reconstruction. This is courtesy Dr. Manda's book. Another example showing a flap 3D TEE in the descending thoracic aorta. So when you take the feasibility and comparison, then except for the aortic branching, the 3D TEE will certainly score over CT and MRI. And when you have a diagnostic protocol, you generally try to have it confirmed by 2 independent techniques. But if it is positive on transthoracic echo, then the patient can be straight away taken up for surgery if the echocardiography is extremely sure, and the transesophageal echo could be performed at the time when the patient is being intubated for surgery, just to confirm it. But when you have a CT diagnosis of type A and type B, then this needs to be confirmed with either a transesophageal echo for type B or a transthoracic versus a transesophageal echo for type A. Therefore, in the emergency room, you should always go for a transesophageal echo. Thank you.
Thank you.